End-of-life care. Hospice is provided when treatment will no longer cure or control the illness. The focus becomes on providing for comfort, dignity, and personal growth as one nears death. The admission to hospice depends on meeting specific criteria and having a primary care provider make a diagnosis of life expectancy of 6 months. The Centers for Medicare and Medicaid Services developed specific criteria, including number 1, the hospice provider and primary care provider must officially state the client is terminally ill. Number 2, the client must agree to palliative care instead of curing illness. And number 3, the client is required to sign a statement they are choosing hospice care to replace other benefits to treat the illness. If the client lives beyond 6 months life expectancy term, an approved hospice provider will need to recertify the client is terminally ill. The client can stop hospice at any time if their condition improves or their illness goes into remission. Hospice care offers respite care support to family and caregivers, including help with running errands, housekeeping, transportation, childcare, and visitation. Hospice provides supportive services for up to 13 months following the death of a client for individuals that have been identified as family and the primary caregiver role. Respite care provides a brief break for primary caregivers, hours, days, or weeks. Caregivers can request the terminally ill loved one be admitted to a professional care facility for a maximum of 5 days. Respite care provides caregivers with an opportunity to rest while knowing that their loved one is being cared for by hospice-trained professionals. Palliative care is initially concentrated on lessening the distress at the end of life. The goal is to improve the quality of life for the individual, family, and caregivers. Palliative care differs from hospice care. Palliative care can be provided while the individual is still receiving curative treatment. Palliative care is not subjective to time constraints. Palliative care services may be suitable and provided long before the client has been identified with a terminal illness. Any client with a life-limiting disease, regardless of life expectancy or prognosis, is eligible to receive this care. Breathing and respirations commonly include dyspnea or shortness of breath, retention of secretions in the respiratory tract, known as the death rattle, and Cheyne-Stokes respirations, which are irregular respiratory rate, fluctuating between several quick breaths and a period of apnea. Opioids, routinely morphine, are the first choice in treating dyspnea. Medication increases peripheral vasodilation, which is the widening of blood vessels to permit increased oxygen flow, reduces the sense of breathing difficulty, and decreases anxiety. Oxygen therapy is used to help relieve dyspnea. If death is imminent, comfort measures such as positioning, using a fan to facilitate movement of air, reducing exertion, and relaxation techniques should be the focus. Anxiolytics or benzodiazepines are used to help relieve anxiety associated with difficulty in breathing. The death rattle is caused by the accumulation of secretions in the lungs and throat. This causes congestion and a rattling sound as the secretions become trapped. The death rattle is an indication of approaching death, often hours or days. Turning the head to the side or rolling the individual to the side can assist with the drainage of secretions from the throat and lungs. Medications such as oral atropine drops or scopolamine patches are used to assist in drying up the secretions. A moist washcloth and oral suctioning can be used to eliminate secretions from the mouth. Cheyne-Stokes respirations. These are visible changes in the client's pattern of breathing. Typically occurs within 3 days of impending death. The rate of respiration becomes irregular, fluctuating between several quick breaths followed by periods of apnea. Pain management is critical to ensure adequate relief from pain and that the individual does not suffer unnecessarily. According to the American Nurses Association position statement, the nurse has an ethical responsibility to alleviate pain and suffering, individualize interventions, and use a variety of methods to relieve pain. Pharmacologic treatment includes the use of non-opioids and opioids. Pain control begins with the use of non-steroidal anti-inflammatory drugs or NSAIDs. If pain is unrelieved or increases in intensity, codeine or tramadol is recommended. When pain is rated moderate to severe, morphine is prescribed. Non-pharmacologic interventions include diversion, relaxation exercises, imagery, massage therapy, breathing exercises, music therapy, spiritual practices, changes in lighting or noise, repositioning, use of cold or heat therapy. With temperature, the nervous system's ability to regulate the body's temperature diminishes, causing episodes of increased and decreased temperature. Chemotherapy decreases the immune system's ability to respond to infection, which can often lead to sepsis. Cancerous tumors can cause elevated temperature. Modeling of the skin is expected in an ordinary physical change that occurs hours to days before death. The upper and lower extremities will become cool to the touch, with purple or reddish marbling of the skin. This is a result of the heart's inability to pump blood effectively, leading to decreased blood perfusion. Modeling often begins in the feet and moves up the legs. It is an indication of impending death. Vision and hearing, the individual may experience hallucinations, a sensation that something is there when it is not. Hallucinations may include all the senses: hearing, sight, touch, taste, and smell. The goals for the end of life are preventing social isolation. This can cause loneliness and adversely affect one's health. Loneliness is an emotional condition where there is a perception of insufficient love, closeness, and social communication with others. Social isolation is the inadequate contact with or relationships with people. Maintaining dignity and sense of control. According to the American Nurses Association Code of Ethics for Nurses, the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. Dignity is regarded as an everyday necessity that is essential to one's well-being. Spirituality for the individual is when the nurse is attempting to be present, to acknowledge one's viewpoint sincerely, and provide holistic care that emphasizes dignity. Near the end of life, illness will create a loss of control, which lessens one's sense of dignity. Control is the client's perception of and their ability to take care of their own life situations. Spirituality has no universally recognized definition. Religion is based on specific beliefs and values shared in the worship of a higher power. Spirituality speaks to one's existence, centered on significance and purpose of life, the relationship with others, nature, and higher power. Spirituality offers a method to cope with impending death and provides hope for life after death. Good death. When one is actively dying, providers, family, and caregivers are instrumental in providing a good death. This is pain management, planning for death, closure at the end of life, clear decision making, and contributing to others. Pastoral care referral. Managing hospice care includes the integration of spiritual services. Hospice spiritual leaders are professionals who provide services in various settings to clients, families, and their staff. They offer spiritual care to people of all religions and denominations. Diversity considerations and culture. Culture is the social structure that shapes one's views, behaviors, and preferences. The quality of care is increased with the acknowledgement of the client's perspectives, experiences, and values. Religious and cultural beliefs should guide pain management. Many cultures do not agree with the use of opioids. Education will include the dosage of opioids can be increased, and there is no limit on the amount of opioids. Legally and ethically, the nurse is obligated to provide qualified interpreters when communicating and providing care for a limited English proficiency client. Post-mortem care is the physical care performed after one has died to prepare the body for viewing, autopsy, or release to the funeral home. With death, the nurse documents date and time of death, name of anyone notified, location of the individual's belongings, and where the body is moved, like the funeral home. Interventions included with post-mortem care are washing the body, making sure possessions are accounted for, and placing at minimum of 2 identification tags on the body in 2 areas: the toe, the arm, or outside the body bag. Organ and tissue donation. Healthcare personnel that provide direct care are not to discuss organ or tissue donation. This policy protects the nurse from alleged conflict of interest. Healthcare professionals who have completed a course provided or endorsed by an organ procurement organization initiate the request of the client or surrogate. Organ donation is voluntary. The donor must give authorization before death, or the surrogate can give permission when the client has not previously consented to organ or tissue donation. Managing healthcare member grief. Often, nurses become close to individuals when working in hospice. They go through a grieving process, and the common physical signs and symptoms the nurse may experience will include a feeling of tightness in the chest or inability to breathe, muscle discomfort, headaches, agitation, sleep disturbances, gastrointestinal problems, and heart palpitations. Psychological signs and symptoms include anger, irritation, unhappiness, sleeplessness, exhaustion, a difficulty staying focused, and altered eating patterns.